Welcome once again to the JPEF 12th edition, and I congratulate Dr. Jyoti sir for such a smashing program. Moving on, we have the JPEF-AIAARO symposium now, and a very, very relevant question: are we doctors failing people living with obesity? And after the first three riveting talks, we are going to have a very, very cogent panel discussion. And I urge you all to enjoy this session, be ready with some important questions, and we will go through that session well. So without much ado, let me invite our president of AIAARO, which is the All India Association for Advancing Research in Obesity, and that's none other than Dr. Mahendra Narwaria sir. And he's the chairman of Asian Bariatrics Private Limited and a very, very renowned surgeon from Ahmedabad in India. And he's going to tackle BMI is dead, why are we still using it? This is a keynote lecture, and let's felicitate Dr. Narwaria sir. So sir, you can start with the lecture. We'll felicitate at the end of the lecture.
Jothydev and his team for giving me this opportunity to come here. I'm the only old man talking in the audience. I'm a bariatric surgeon, and today we'll talk about BMI. It's a dead, why we are still using it. And I'll give you a historical background of it. It's born in 1983, still making medical decisions today. Is it really required? And if you look at the historical part, it was so much happened in last so many years that BMI was used for different reasons, but I'll give you background why it should not be used. BMI was never meant for clinical use because there is no assessment of fat distribution or even its health status. And what BMI misses, not all weight is fat and all fat is unhealthy. There is no insight into visceral fat, sarcopenia or fat quality in any of these individuals when we measure the BMI. Ethnic and gender bias in BMI, the South Asians develop metabolic disease at lower BMI. Everybody knows that we Indians are even getting diabetes at lower BMI. The women and elderly people are more misclassified. And sarcopenic obesity and thin fat phenotype, which is the new disease which is coming up, which was published by our own friend Dr. Sanjay Kalra. BMI is normal, but metabolically sick patient, which is the commonest patient which we are treating today. Central obesity and BMI, if you look at the comparison, the waist to height ratio, that is waist to height ratio more than 0.5 predicts cardiometabolic risk as a better. Body composition term with BMI, the bioimpedance analysis, DEXA, MRI for precise adiposity, lean mass are more precise and better tools to measure adiposity. In the real world concept of using BMI, it is always causes delayed in diagnosis, imperfect decision or denial of the therapy. Like GLP-1 access and BMI barriers, so far whenever we prescribe GLP-1, depending on the BMI, many people are not getting the treatment or access to these medicines which are very, very effective in losing weight. This was published by Rubino in year 23. Like similarly, we have surgery eligibility criteria which were all depend on BMI cutoffs, but we don't know who decides and who qualifies for bariatric surgery. Traditionally, BMI more than 35 was audited. Our recent publications by International Federation for Surgery for Obesity on and American Society of Bariatric Metabolic Surgery, they modified the BMI criteria now. The new guidelines support the BMI of 30 to 34.9 with communities are eligible candidates for diabetes surgery or metabolic surgery. In Rubino Commission, which was published in year 23, obesity is an adiposity-based chronic disease and recommends abandoning BMI as a sole diagnostic tool. Time to diagnose obesity holistically, that means we need to consider function, risk and adiposity and not just BMI. This is a clinical scenario wherein the BMI of 29.5 is CL, NFLD, PCOS, insulin resistance. If we just treat only due to BMI, we may not be giving justice to this patient. And insurance may deny surgery to these patients who really need metabolic surgery to cure all these illnesses which are there. So beyond BMI, there is a multi-dimensional staging system by Edmonton Staging System EOSSS by Dr. Sharma from Canada, which was being more commonly used nowadays to treat obesity. There are better tools like waist to height ratio, BIA, metabolic risk cluster, liver fat percentage to treat these patients. So there should be a policy change and practice should shift and to advocate the insurance and guideline reforms. In bottom line, BMI is a screening tool, not a decision tool. So don't get it and keep care. So I'll give you a simple example here, the Narwaria and Saboo paradox. So everybody knows Dr. Saboo here. You have seen me also now. And here we will be just comparing our analysis which we just did yesterday. When we were coming to Ahmedabad, at Ahmedabad airport only, we did this analysis. If you look at the height, we both are almost same height. Weight-wise, almost I'm 8 kg more than him. But fat mass-wise, my fat mass is more and body fat is more. But percentage-wise, my fat percentage is 32.8 compared to his fat percentage, which is 33.7. So look at the chart. This is a comparison of me and Banshi. So you can just see the visceral fat is more with Banshi, even though his BMI is low. Similarly, fat percentage is more. Skeletal muscle mass is much lower than me, though our height is same. Truncal fat mass is more in my analysis, not in him, but central obesity or central fat is more dominant in his case compared to mine. I have in peripheral fat. So, if clinical implication of this analysis is the more visceral fat, lower muscle mass and higher metabolic risk in case of Dr. Banshi Saboo compared to higher muscle mass, better cellular health and relatively preserved metabolic profile in my case. So you just see how the paradox is existing in our own real world, which we can compare. That means BMI does not fully capture body composition. The management approaches differ for each individual. Myself having more muscle mass, Dr. Banshi has less muscle mass and more central obesity, which is putting him at risk. The innate phenotype shows lower muscle mass, need body composition analysis in clinics, and higher visceral fat and insulin resistance are common in central obesity, and global BMI cutoffs does not fit Indian risk factors. BMI alone is insufficient for Indian obesity care. They incorporate this paradox in medical teaching and workshops. Personalized treatment based on body composition, always we should analyze this and consider visceral fat, muscle and fat pattern as a key factors to treat these people. So same was published in Lancet Commission, who has never talked about BMI in any of his, so they defined it preclinical and clinical obesity. So in preclinical, those who are not, there is no evidence of organ or tissue function due to reduction due to obesity, and can complete day-to-day activities are unhindered and are generally or at a higher risk of developing disease such as clinical obesity, cardiovascular disease and some cancers and type 2 diabetes. But in clinical obesity, they develop breathlessness due to obesity leading to heart and lung dysfunction, cluster of metabolic abnormalities, dysfunction of other organs including kidney, upper airway, nervous system, urinary and reproductive system, and knee, hip joint and other parameters are included in it. So here there is no talk about obesity. Similarly, diagnosing clinical obesity, although BMI was useful in identifying individuals, but it does not direct measure of fat, it does not establish distribution of fat amount in the body, and it cannot determine and when the excess fat is health problem. This is Rubino Commission, which was published in 23. BMI is a population-based tool, not meant for individual clinical decisions. It ignores fat distribution, visceral or subcutaneous fat. It ignores metabolic health, which includes insulin sensitivity or inflammation, body composition, whether it is sarcopenic obesity, MONW or MHO, ethnic variability like South Asians, East Asians, and high visceral fat with low BMI patients, and BMI lacks diagnostic specificity, sensitivity, and relevance to health outcome in individuals patients. So the clinical message that we should reframe obesity as a disease not as a number, diagnose based on adiposity and its impairment, not BMI, refer for surgery or medical treatment even though the BMI is 35 with existing comorbidities below 35, and advocate for access, equity, and evidence-based thresholds to treat these patients. So as a takeaway, this is my last slide to thank you. The BMI is simple, but obesity is not simple. Let's give our patient a better tool and better care. Thank you so much.
Thank you, sir. Can we have the memento, please?
I now invite our chairperson, Dr. Purvi Chawla, to give a token of appreciation to Dr. Mahendra Narwaria.
Working together since years. So he is, from childhood, he is having a habit of doing a lot of exercise, and it's more of a muscle strengthening exercise. While I was having more of an idea of doing a regular cardio and to eat less. So it's not just the carb eating less which will be sufficient. Yes, definitely it will help to improve your glucose control, for your weight reduction, but may not help for increasing your muscle mass. Muscle mass increase is must for increasing your insulin sensitivity, for long term of your reversal or remission of diabetes, for not to get the cardiovascular disease. And we are not doing very intensive cardio also. I mean, if you just ask that how much exercise you are doing just for a 30 minutes walk is not sufficient. So doing a 45 minutes to 1 hour, a good exercise along with a cardio of 30 minutes and maybe alternate day and a 15-20 minutes of a pranayama, I think will be the best way, because that will help your increasing your nitric oxide, muscle mass increase will improve your insulin sensitivity, visceral fat decrease will decrease your risk of cardiovascular disease. And that's what Indian Obesity Society is going to do, the AIAARO at a national level, to increase awareness for this obesity and other complications to be prevented in diabetes and obesity. Thank you.
Thank you, sir. Sir, don't leave stage. Please join us for the panel discussion.
So just to add my lifestyle, my weight gain was only because of the weekends where I'm in the different conferences. Like we are here today, so for 3 days we'll be eating, but we'll not get time to do exercise. So I think if we can make a habit of doing exercise and eating less, but at least protein should be there as part of every meal. That is the most important. In our state, Gujarat, our vegetarian diet has more carbs and less protein, which we just changed recently, and we are working on it, and mostly by next year, both of us will come with a different composition.
Thank you.
Great. So let me just take a very short interlude and invite our panelists also on stage before we move on to the second talk. With that, we have Dr. Polina, who's the head of Research Laboratory of Metabolic Diseases and Microbiota, World-Class Research Center for Personalized Medicine, and the head of Research Laboratory of Endocrine Diseases in Pregnancy, Institute of Endocrinology from St. Petersburg, Russia. So we are very happy to have you with us. Thank you for joining us. Very humbly, I will introduce Dr. Banshi Saboo sir as well, the Chief Diabetologist and Chairman at DiaCare, Diabetes Care and Hormone Clinic, Ahmedabad. But I think as established as he is in India, he is established globally as well. So Global Council member of EASD, chair of IDF Southeast Asia, and I could go on and on, but I'll cut it short there. There are many, many different facets to Dr. Banshi Saboo sir's introduction. May I also invite Dr. Benny from Trivandrum. He is the professor and head Department of Community Medicine, Sri Gokulam Medical College, Trivandrum, and the national convener for IMA Food and Nutrition Initiative. Also the vice president of the AAAARO Kerala chapter. Welcome, sir. And next we have Dr. Anita Nambiar ma'am. Again, who doesn't know her? She is also going to be organizing the RSSDI Kochi coming up very soon. She is a senior consultant physician at the VPS Lakeshore Hospital and RSSDI chairman-elect of the Kerala chapter, organizing secretary of RSSDI National Conference 2025 Kochi. Welcome ma'am to the panel discussion. We also have another very dynamic lady with us, Ms. Geethu from Trivandrum. She is the chief dietitian at Jothyedev's Diabetes and Research Center, involved in the follow-up of patients via tele-management system at JDC, and we know how big they are, and has several other aspects to her. She's also the treasurer of AAAARO Kerala chapter and many other things that she has in her hat. So welcome with that. Do we have Jyoti sir yet? Okay, so the chairman of JPEF is also going to be part of the panel discussion, and we'll await his entry. Before that, let me move on. Our second talk is by a very, very dynamic nutritionist, Ms. Shiny Surendran, and it gives me great pleasure to invite her. She is she runs a sports dietitian program from Chennai and part of the Sports Dietitians Australia. She is also the ISAC Level 2 Kinanthropometrist from New Zealand, also has FODMAP certification for IBS, and is a very, very dynamic, I don't even know how many Instagram followers she has, but she's very sound in her clinical work, and that's why she's here at JPEF-AIAARO Symposium. And without much ado, please join us for your talk on the clinical approach to weight loss in Indians.
Good afternoon, everyone. And Banshi sir and Narwaria sir, it takes a lot of courage to actually display your numbers out there. Don't you agree? I think we should applaud them because it's not easy. A lot of people don't even want to reveal their weight, and here you gave the entire horoscope, right? Your body composition analysis. So thank you so much for sharing that and sharing also your lifestyle. So great takeaways. Thanks so much. And Dr. Jothydev, Sunita ma'am, thank you so much for having me here as one of the speakers and being part of this panel. And thanks Purvi for this very kind introduction. Very happy to be part of this eminent panel. So because there's only that much time and the time has ticked off, I'm going to quickly share some of the things. We know what crisis we are facing, and it's been there in all the papers about what we are going through, and it's not just the adults, also the children, right? And these are the numbers that we are looking at right now. And if you look at the India study, that is ICMR India study, which was recently released, and there's been a lot of discussion about how the metabolic syndrome is such a huge crisis, and the pre-diabetes itself in this country is around 136 million. So it's not easy at all. We really need to look at the numbers, and what can we do at the grass level is the most important factor. And of course, here again, if you notice, so I'm sure you would have looked at the recent paper, and we do have MONO, that is the Mono as well as MOO is the metabolically obese category, and MHNO, which is the metabolically healthy but non-obese, and the metabolically healthy obese. So look at the percentages. So there are a lot of people who are very thin, and even in our clinics we do, I'm sure all of us do see lean PCOS, right? People are thin, but then you know how they present themselves as the waist to ratio could be really high, and the emphasis is so much on I'm going for a walk, I go for a run, I do cardio, and weight training or strength training goes for a 6. Most often a lot of people do not focus on strength training, and I think that is one of the biggest reasons. Another factor which we also notice in the female population is there are a lot of this yo-yo dieting which happens. So they lose weight, they regain weight, and this goes on, and what they end up losing is a lot of skeletal muscle mass, and we really have big issues there, and they represent, or rather they present themselves with PCOS initially, and then later we see GDM, and then of course progressing to type 2 DM, and of course somewhere in between MAFLD. Okay, so we all understand how important it is to look at obesity very, very seriously. So just sharing one of the studies here, again, here it is important for us to ignore the BMI, but then look at the body composition analysis, depending on what the individual can afford. So be it a DEXA scan, or else it could even be a body composition analysis by using a bioelectrical impedance analysis principle. So these are things which are very comfortable at the clinic level. In fact, when we work with athletes on the ground, we use the skin fold caliper. But again, it requires a lot of practice, and there could be a lot of human error. So I think a body composition analysis is something which is very affordable. What Sir had, Narwaria Sir had mentioned just now. And I think you have a kiosk in Ahmedabad airport, correct? Yeah. I think that's brilliant. It's a fabulous marketing strategy besides raising a lot of awareness. I think that's remarkable what you have done. So anyone who has some time and who's just walking around can just quickly go and get it done. And not many clinics actually have it, and I think it's a great investment tool. And rising, these are the global rising obesity trends, and it's not just, I think during the pandemic, a lot of children have also been facing, and because of that, the impact is still there. Screen time has gone up, they go to bed late, NEAT calories or the non-exercise activity thermogenesis itself is quite low. And this is one of the major contributing factors. And I'm going to skip this and move to the next slide for the lack of time. I think I have just 7 minutes to go. So when you walk less aerobic activity, and then when fiber is compromised, and another factor is also when you're not actually getting a balanced diet, there are a lot of micronutrient deficiencies. They might be, individuals might be obese, but then there could be a lot of micronutrient deficiencies. And then also not having breastfed is another major factor. And a lot of people imbibe Western diets. So it's the culture, you know, which has been imbibed, and not actually eating the local food, and access to fast food, and also you can order food 24/7. So you do have Swiggy and the Uber Eats and whatnot. So I think that's another bane that we are facing right now. And of course the screen time has also gone up. So 40-50 years back we only had Doordarshan, but right now you're spoiled for choices, and I'm sure you would all agree on that. And continuously for 3 to 5 hours of screen time. So one of the important questions to ask during assessment is, what is your screen time? How many hours do you spend on your iPad, your phone, as well as television? And whether the television is in the living room or in the bedroom. And where do you eat your meal? And I think these are things that go into our assessment form. And one more thing is the comorbidities that's associated with us. We can see head to toe, we all know how difficult it is to handle when people present with 4 or 5 comorbidities, and it's a huge challenge, and I think that's where the drugs are coming in very handy. And what we get to see in the Indian population is, of course, the waist-to ratio being very, very high, the central or the truncal obesity, and this again is a huge issue. So when we do a body composition analysis, we can clearly demarcate and tell them your android and gynoid fat is this much, or else your visceral and subcutaneous is this much. So you really need to up the game and step up the skeletal muscle mass. So weight training thrice a week becomes important, or else do any sort of weight-bearing exercises. So central obesity, or measuring the waist circumference, is very crucial. Using something as simple as a tape, you know, just to measure the neck circumference, the chest, as well as waist, abdomen and hip, and also the thigh measurement, you know, and of course the arm measurement. These are simple things that we can do it right in our clinic. And we also know the thin fat phenotype which, just sharing the study, because this is something that we get to see in India, especially across the country. We see a lot of people who are very, very thin, and they seem to be quite unaware of the fact that they could be metabolically unhealthy, and that's when assessments are very crucial. This is just from the recent article which came Times of India. Dr. Amrish Mittal's quote is also here. Again, it's all about, the thin fat phenotype is what we're looking at. So just because a person is thin doesn't mean they are healthy. So getting a fitness assessment also becomes very, very important. So it could be measuring the waist to hip ratio, or else it can even be the BCA analysis, or the waist circumference itself, or the waist to height ratio, which was done in the India study. And sarcopenia is another thing. So you have all these fat diets coming. There are so many fat diets across ages. I'm sure you would have seen even before the pandemic, a lot of low carbohydrate, high fat diets were there. And right now there are also 600 to 800 calorie diets, which is very, very popular. And people end up becoming sarcopenic. And just like how Narwaria sir and Banshi Saboo sir mentioned about the importance of skeletal muscle mass and how it is important for improving insulin sensitivity to clear the blood sugar from the system. So I think it's important that we keep emphasizing, raising awareness on increasing the lean muscle mass. And people don't realize, first time around they might lose a lot of weight, and then you meet the individual after say a year, they might have regained. And when this cycle keeps going back and forth, over a period of time it gets difficult, and then they resort to extreme diet plans. So it could just be 3 meals of meal replacement, or it's just being on liquids, and then what they're losing is a lot of muscle if they're not supporting it with adequate protein, omega-3, as well as strength training. I'll just skip this slide. So what are the things that we should really look at? Grip strength is something that we really need to look at, and you do have the SARC questionnaire. And another factor will also be to periodically, at least twice a year, of DEXA, or if you have a BIA machine like what sir had displayed on the screen, that can be done like every month. These are things that we use in the clinic also. So every month a client would come and see how they have progressed and whether there's a drop in the visceral and the subcutaneous fat. And also muscle function tests. Even a 1RM test could be done, and you need to see how they are able to do regular activities. I think even to carry a bucket of water and taking it from one room to the other, or perhaps even to the terrace, or even carrying groceries from the car to the house, how much are you able to handle without having a disc prolapse or else a back pain? I think these are indications whether an individual is strong or whether he or she has enough muscle mass. Okay, so BMI, we all know how it's obsolete, and we shouldn't be looking at that at all. And these are diagnostic tools, and I think this is one very important study, and this was a very nice image, or else a picture. I would encourage all of you to have a look at it. We really don't have time to go in detail, but I think this is something that we should have as a marker, and it will guide us through our practice in our clinics. And of course, these are the guidelines from the Endocrine Society of India, and the emphasis is so much on fine-tuning the carbohydrate, ensuring that there's enough fiber, protein in the diet, limiting saturated fat to less than around 7%, and cholesterol below 300. And we all know how Indian diets are deficient in protein, so let's not miss out on that aspect at all. And emphasizing on complex carbohydrates, because zero-carb diets and low-carb diets are very, very popular. Okay, so this again is the ICMR NIN guidelines. I would request you to take a picture because going in detail, we don't have the time right now, but it's all about smart snacking, making sure that you have a balanced diet. I'll show you a plate picture, ideal meal plate, and also including a lot of protein. It's not about cutting out the mutton or the chicken. It's all about the method of preparation and trimming the fat before cooking. And see, another factor is also the religious things, the fasting rituals that we follow in our country. A lot of people, even if it is a non-vegetarian, might not eat non-veg every single day, right? I'm sure you would agree. There are days like a Thursday, Friday, or a Saturday, an individual might not eat. And then the quantity that they eat probably over a weekend might be quite high, but it will not be distributed evenly throughout the week. Okay, so this is another most important factor. So protein is something which is lacking, and there are plenty of options these days, be it a plant protein or else a whey protein or whey concentrate, even for the ones who go to the fitness centers, right? Besides what is available naturally. So these are some of the vegetarian protein sources in 100 grams of the food product, and there are plenty of options that's available in the market. So be it even a lactose-free milk or else tempeh and tofu, and plenty of recipes online are available. And I think lentils is something that we can definitely explore, but let's remember 40 to 60% is carbohydrates, complex carbs are there. So just by eating a cup of chana or rajma, let's not tell ourselves, oh, we've got a lot of protein today. No. Kindly do keep this in mind. I think education is very crucial when it comes to our patients. Of course, these are the non-veg sources. And next, of course, is we also have to see the environment. We'll have to plan dietary strategies. We'll have to teach our clients what to eat in different circumstances, be it the airport, the lounge, be it even a pub or else a bar, be it weddings, vacations, because people easily gain 5 to 7 kgs on a holiday for 2 weeks. I'm sure you would agree. May, June, I don't know how much of damage has happened. So here mentioned about the conferences and what kind of food they get to eat and how it contributes to weight gain. So we'll have to look at the individual in different scenarios and also educate them, equip them, raise awareness. These are some of the healthy swaps. I would request you to take a picture. I'm almost towards the last slide. Okay, this again is a very good meal plate. You just have to split the plate into half and making sure that one semicircle is filled with vegetables, and that too non-starchy vegetables. So aloo, arbi, that is your potato, colocasia, yam is best avoided, and then try to focus on a lot of non-starchy vegetables. The other semicircle split into two, one for grains, the other one for non-vegetarian food products, right? So this is a very easy depiction, much easier to educate a client. HIIT, intermittent fasting works for few people. There are few conditions where IF is not recommended. And this is just from our clinic. This is the last slide. I just wanted to show you with constant motivation and then through WhatsApp monitoring, we've been able to help a lot of clients. And these are some of the values that I just wanted to share. Thank you so much for giving this opportunity. If you have any questions, please do bring it up. Thank you.
Thank you, Shaini, for that very, very comprehensive talk. Please join us for the panel discussion.